poor gentleman who seems very short of breath. Uh, Dyspnea, just to say it, is nothing more than an abnormal or uncomfortable sensation of breathing. It's very subjective, and there's some people have minor abnormalities and feel very dyspneic. Other people have major abnormalities and don't feel very dyspneic. So it's very subjective, and it's this subjective experience of breathing discomfort, again, comprised of very different sensations that vary in intensity. And it's also very non-specific. Look at all these patient scenarios: a young person with type 1 diabetes with nausea and vomiting, a man with an acute GI bleed, chronic liver failure with ascites, severe diarrhea, CHF, pneumonia, PE, pneumothorax, COPD. All of these people have the same symptom, or could have the same symptom, dyspnea. So let's talk a little bit more about the pathophysiology of dyspnea. You know, the respiratory system is wonderfully designed to maintain homeostasis with respect to gas exchange and acid base status with the least amount of work possible. And derangements in this balance, or in the work required to maintain that balance, can result in dyspnea. So you really have to think about all these components of the quote unquote respiratory system when you think about someone with dyspnea, from the brain to the spinal cord, to the neuromuscular system, diaphragm, pleura, the lungs, the blood vessels, the blood, and all the way down to the mitochondria. Abnormalities in any of that chain can lead to dyspnea. And some of those abnormalities we'll capture here. So the pathophysiology of dyspnea includes an increased central drive to breathe, either some sort of central disease or medications or psychogenic causes can increase the central drive to breathe, and people feel that as shortness of breath. Excess respiratory muscle work, we talked a little bit about that. Poor airflow and lung stretch. We have receptors in our lungs that detect how quickly air is moving through and how our lungs stretch. And if your lungs aren't stretching properly, it triggers the sensation in your brain of shortness of breath. And then finally, all the things that you already think about related to gas exchange and metabolic demand, hypoxemia, tissue hypoxia, notice the difference in the words there, but oxygenation of the blood, oxygenation of the tissue, CO2 clearance, and acid production all contribute to dyspnea. And in fact, many conditions have more than one mechanism. If we shift from a slightly, physiologic or pathophysiologic mechanism to sort of buckets that include clinical problems, that you can think about it this way: decreased oxygen delivery to tissues, which includes hypoxemia, decreased cardiac output, severe anemia, either absolute or relative, or increased CO2 production from acidosis, fever, hypermetabolic states, or decreased CO2 clearance, dead space, pulmonary embolism, air trapping from COPD, airflow obstruction from asthma or COPD, and then finally work of breathing or respiratory mechanics. These are the buckets that things fall into. So let's switch gears and start talking about some cases and put some framework to some of these mechanisms that we're talking about. So, okay, you're on night medicine. The nurse calls you at 2:30 in the morning to report that Ms. Petunia KO, a 68-year-old woman admitted 5 days earlier for community-acquired pneumonia and a mild COPD flare, now has worsening dyspnea. And the nurse asks you what you would like to do. So you check your sign out, and here's a schematic of what your sign out might look like. She's full code. She has no known allergies. She's here with community-acquired pneumonia and a mild COPD flare. You were told she was stable. So much for that. And then she's got all these other things on her problem list. And so you look at this and you're like, oh my gosh, all of these things could somehow be causing her to be dyspneic. She just had a right subclavian line placed today. Maybe there's like a complication from that. She's getting IV antibiotics. Maybe she's allergic to that or fluid overloaded. She has a history of DVT, CHF, CAD, etc. So you're starting to formulate your differential diagnosis. And you're thinking maybe her COPD is getting worse, maybe her pneumonia is getting worse, maybe she has a pneumothorax from that central line that was placed, maybe she's gone into pulmonary edema with her history of CHF and getting IV fluids, maybe she's had a PE. And so my first question, and Emily, thank you for the poll. My first question for you all is, what would you do next? Order furosemide, order a CT angiogram, go see her, stop her IV fluids, activate the cath lab, or do a POCUS?
We're getting good responses. We have 16, 17, 18. So I'll unleash them in just a second.
Okay, great. Hey, can I answer? It shows up on my screen. Yay, 100% of you said go see her. And of course, that is absolutely the thing to do. So you may wind up doing some of these other things, and we'll get to that as the case evolves. But when you're called about someone with dyspnea, key first steps on the phone, ask for vital signs, oxygen saturation, mental status or amount of distress, and some immediate background. Did something just happen? Oh, we just finished transfusing a unit of blood. And then, of course, you must go see the patient, but you want to ask for these things ahead of time. And then, as you're going to see the patient, you can think about what you want prior to you getting there, based on this information that the nurse is telling you. Do you want to start them on oxygen, get them on a monitor, get an IV started? You want to give them a dose of albuterol ahead of time so that you can actually see if it's had an impact. Do you want a blood gas, a cardiogram, chest x-ray, etc.? So ask for these additional things, and then think, what do you want prior to your arrival? And then go see the patient. Cool. Okay, so you go to see her, and she's in moderate respiratory distress. She's afebrile, tachycardic, normotensive, a little tachypnic. Her SAT is 91% on 4 liters nasal cannula. She has no jugular venous distension. She has some right basilar crackles, occasional soft wheeze with good airflow, bilateral pretibial edema that's a little asymmetric, 1+ on the right and only trace on the left. And so you're thinking, okay, what would you order next? And I'm going to give you some additional data before the next poll. So you get a chest x-ray, and the chest x-ray shows a right lower lobe focal opacity consistent with her community-acquired pneumonia, no change from admission, and no evidence of CHF, no pneumothorax. Her blood gas, though, is 748/3462. She has a respiratory alkalosis, and she has a widened AA difference. Her baseline on 2 liters was 739/4378. So her blood gas is worse. Her cardiogram shows no ischemic changes. And again, you're thinking, okay, now what do I do next? And so when you get to this step, I want to introduce my 3 pillars of care for a patient with dyspnea. The first pillar is get a safety net in place. Make sure the patient's safe. And you already thought about this as you got the phone call. You want to get oxygen on, you want to get IV access, and you want to get the patient on monitors. The second pillar is assess your vital signs, which I just gave you, for example, in this patient: pulse, blood pressure, respiratory rate, temperature. You definitely want at least a pulse oximetry reading, and you may want a blood gas, and their mental status, which is part of the vital signs. And then you want to do your dyspnea survey, A, B, C, D, E. And that's your quick dyspnea survey. And this dyspnea survey, remember, I introduced these physiologic buckets, but the dyspnea survey of A, B, C, D, E is airway, breathing, circulation deficits, meaning neuromuscular deficits, and electrolytes or extras. And so this is a clinical. It takes those physiologic buckets and creates clinical scenarios. So could airway, partial airway obstruction, breathing, she have COPD, worsening pneumonia, pneumothorax, circulation, anemia, PE, shock, heart failure, worsening neuromuscular deficits of some sort, and then various electrolyte abnormalities here. And so again, thinking about this first patient I told you about, she's got most of her things under B and C: COPD, pneumonia, pneumothorax, heart failure, cardiac ischemia, or pulmonary embolism. So now remember the story I told you. Here's the next question. What would you do next? Would you calculate the pretest probability of pulmonary embolism? Would you order a BNP? Would you order a D-dimer? Order a CT pulmonary angiogram? Order a VQ scan? Or order an echocardiogram? How are we doing, Emily? Are people answering?
Yeah, we're at 18 responses, so maybe just one more second. Okay. All right, I'll end our poll.
Fantastic. So about half of you wanted to calculate the pretest probability of PE, and then a smattering of other things, but a third of you wanted to go straight to CT pulmonary angiogram, and because you're suspicious of PE. I want to argue that I think that we really need to get more into the habit of calculating pretest probability, and I'll show you why in a minute. There are a lot of different tools to calculate the probability of PE: the Wells score, the Geneva score, a couple of others. They're all on your phone. I don't know of too many studies that say one is absolutely the best. So you can use whichever one you're comfortable with. I'll show you both Wells and Geneva. So the Wells score asks, are there clinical signs and symptoms of DVT? She has asymmetric edema, and so she gets points for that. Is there an alternative diagnosis that's less likely than PE? Is an alternative diagnosis less likely than PE? In other words, is PE the most likely diagnosis? This is the one flaw I have, by the way, with this clinical prediction model. That's what you're using the model for, is to tell you. But in the Wells model, it asks you about this. So maybe she gets points for that because you're thinking about PE. She's tachycardic. She has been immobilized. She's been in bed for the last several days. And so she has a history of a previous DVT, and so she gets 7.5 points, and that's a high pretest probability. Greater than 6 points is a high pretest probability for PE. The revised Geneva score is also a great score. It takes away that subjective question in the Wells score, but if you go through here, she has 13 points for these categories, and that also puts her in a high risk pretest probability scenario. And so that's important. And the scores, it came out the same with both scores. D-dimer is something that people think about. The best use of the D-dimer is actually when your clinical suspicion is low. If you have a low pretest probability and a negative D-dimer, you can probably stop. But if you're planning to do further testing anyway, based on your pretest probability, there's no need for a D-dimer. And a positive result is not diagnostic, especially in hospitalized patients. We know this very well, that it is way overly sensitive in hospitalized patients. And so we generally would not order a D-dimer in a scenario like this. The reason why pretest probability is important is based on this study. This is already now an old study, the PIOPED-2 study, which compared CT pulmonary angiogram to the Wells clinical probability score to a true positive done by invasive angiography, pulmonary angiography, which we almost never do anymore because of the advancement in technology. But I just want to remind people that if you have a high pretest probability and your CT angiogram is negative, there's still a 39% chance that the person actually has a PE and that it's a false negative CT angiogram. And then you would have to think about what else to do for that patient. Similarly, if you have a low pretest probability and your CT angiogram is positive, there's a 38% chance it's a false positive. And it's interesting to me how culture has evolved to take CT angiography as the gold standard. But when invasive angiography was the gold standard, we learned that CT angiography is not perfect. And so coupling it with a pretest probability is really important. Well, in this woman, she had a high pretest probability, and she got sent for CT angiography. Here's a cut from her CT pulmonary angiogram, and you can see this large clot on the right and pretty extensive clot on the left. And so she had pulmonary embolism as the cause of her dyspnea. So just to summarize then, if you're thinking about VTE, calculate a pretest probability with one of these scores, all of which are on your phone. Do your basic studies, a cardiogram, a chest x-ray, maybe a blood gas. D-dimer is not helpful. On Occam, we have the diagnostic algorithms for working patients up. Most of the time you will go, if you have a high or intermediate pretest probability, you'll go to CT pulmonary angiogram. Sometimes that's contraindicated and you can do either a lower extremity duplex or a VQ scan. In her, a VQ scan, which again, we don't order very much anymore, would not be very useful because she has a history of obstructive lung disease and pneumonia. So you already know that's going to be abnormal. And then I'll just remind everybody, sometimes it takes an hour or two to get patients down for a diagnostic study. And you should always ask yourself, if you have a high pretest probability, do I want to start therapy before the study. And that's generally considered the gold standard as well. If there's no contraindication, start heparin. And if the study is going to be delayed at all. Nice in our, we're spoiled in our system. We can get CT angiograms pretty stat, but that's not always true depending on where you are. Okay, case 2. Let's go to case 2. You're the night medicine intern again. Maybe it's the same night. A nurse now calls you at 3:30 to report that Mr. William Power, a 65-year-old man, admitted for anemia of unclear etiology and COPD, now has worsening dyspnea. The nurse asks you what you'd like to do, and you check your sign out. And here's a schematic of your sign out. And also full code, no known drug allergies, admitted with anemia and a mild COPD flare. His crit was 22% on admission. He's got gold stage 3 COPD. He's on prednisone and inhalers, sub-Q heparin. And his anemia workup is ongoing, although it doesn't appear to be a GI source. And so you're thinking as you're going there, could this be worsening COPD? Is it pneumonia? Did he aspirate? Is his anemia worse? Has he gone into heart failure? Is he septic? And so I'm going to not do a poll for this one, but you're thinking, okay, do I want to give him Lasix? Do I order blood? Get a Coombs test, activate the cath lab, or go see him, and you are going to go see him. And so this is what he looks like. He's an older man. He looks ill. He's a bit overweight, but he's alert and he's oriented. Vital signs, he's tachycardic, hypertensive, a little bit tachypnic, 38.1, SATs 89% on room air. He's in respiratory distress. He's diaphoretic. He's got wheezes and rhonchi and scattered crackles and a prolonged exhalation phase. But he has no JVD, no peripheral edema. How would you care for him now? So the next poll is, which of these would you not order? Bedside peak flow monitoring or spirometry, a blood gas, a repeat hematocrit, a chest x-ray, or an order for oxygen?
We've got some good results, so maybe
Good.
get more.
Awesome. 81% would not get peak flow monitoring or bedside spirometry. 10% would not get a blood gas, or at least an arterial blood gas. And so I agree. I don't think there's really a role for peak flow monitoring or bedside spirometry in assessing whether or not someone has a COPD exacerbation. Peak flow monitoring is more of an outpatient tool and primarily in asthma, but less so in COPD and certainly less so on the inpatient side. So let me give you the results of the data for these other things. Here's his blood gas. He has a respiratory acidosis, 72954, and his PO2 is down to 58. His repeat hematocrit is still 21%, or hemoglobin of 7. So that hasn't changed. His chest x-ray has changes consistent with hyperinflation, but no new opacities or edema. And so what do people think is going on in this case? And I don't have a poll for this, but either unmute and shout it out or pop it in the chat. What do you think is happening here? Anybody? Okay. No one wants to shout out, but this is a COPD exacerbation. That's what's happening here. And so I'm not going to go over too many details about how to manage acute COPD, but oxygen therapy, albuterol and Atrovent for acute short-acting bronchodilation, steroids for non-ICU patients, 40 milligrams of prednisone, um, or the IV equivalent, once daily. There may be a role for limited spectrum antibiotics in a COPD exacerbation, such as a macrolide. Always think about diuretics in someone with dyspnea or some sort of pulmonary condition. My mantra is dry lungs or happy lungs. I've said it for years, and you've probably heard other people say it as well. But always, sometimes diuretics are contraindicated, but often they can help. And then there's non-invasive or invasive ventilation for patients with COPD. And so just to summarize, bedside spirometry is usually not helpful. I would argue that an arterial blood gas usually is helpful, unless you have a baseline VBG for somebody. I think in the initial assessment of patients like this, where because of their lung disease, they can have an abnormal arterial to venous carbon dioxide gradient. And so doing the usual, 5 less than the PVO2, PVCO2 is the PaCO2, doesn't always hold in these patients. So sometimes an initial arterial blood gas is really helpful. You usually need a chest x-ray and a cardiogram. And then you still need to think about, why is there COPD flaring? And there are other considerations for that. And then, as you know, most patients with hypoxemia in the hospital, we will target a SAT of between 90 and 94, 95%. There are actually data that targeting higher saturations can be harmful, except in patients with severe anemia, where their oxygen delivery is reduced, and then a higher SAT can be helpful there. And in COPD patients, we target a SAT of 88 to 90, 92%. And in COPD, both over and under oxygenation can be bad. So how we do? Oh, we're doing great on time. Fantastic. Okay, case 3. 82-year-old man, history of dementia. He's admitted with fever and a decubitus ulcer over his sacrum. He's getting wound care. He's on Pip-Tazo, and he's getting enteral nutrition. And you're called to see him for dyspnea. And so, again, your initial differential diagnosis that you're kind of thinking about as you're going to see him: does he have a mucus plug? Could he have pneumonia? Did he aspirate? He's getting enteral nutrition. Is he volume overloaded? Did he have a PE? Does he have respiratory muscle fatigue, sepsis, overfeeding? Sometimes feeding people too many calories causes increased CO2 production and can cause dyspnea. So you go see him, and he's somnolent, but he's awake. He's in moderate respiratory distress. He's febrile, tachycardic, a little hypotensive, very tachypnic, and his SAT is 97% on 4 liters nasal cannula. No JVD. He's got a few bibasilar rhonchi, but no crackles or wheezing. Bilateral trace symmetric pretibial pitting edema. His chest x-ray shows low lung volumes, but is otherwise clear. His cardiogram shows sinus tachycardia, but no ischemic changes, no changes from baseline. So what do you want next? What next test do you want? Hopefully you're thinking of a blood gas. So here's your blood gas: 747, 25, 89. So he's oxygenating on room air. but he's alkalemic and his PCO2 is low. So as the next step, you get a basic metabolic panel, and this is what that looks like. 144, 3.2, 106, 18, 38, 1.7, and 168. How do people interpret this? Oh, some WAGMA. What's wide? Yes. Okay. Cool. I just use AGMA. Yes. There's an anion gap metabolic acidosis. Absolutely. The anion gap is 20. But he's not acidemic because he also has a primary respiratory alkalosis. He's got this mixed picture. What does that signal to you? What do you think's going on with this guy? What could cause both an anion gap and a respiratory alkalosis? Aspirin. Yep, aspirin could do it. Great thought. His aspirin level was negative. Fantastic. Good. Any other guesses? Well, it turns out that sepsis can do this. We all know about sepsis causing a lactic acidosis, and that's what was going on here. He had a lactate level. But sepsis can also cause a primary respiratory alkalosis. Early in sepsis, the cytokines actually are respiratory stimulants. And I can already tell you that it's inappropriate if we did Winters because he's got a primary respiratory alkalosis. But yes, absolutely, we could do that. So this guy is septic, and so please remember that sepsis can initially present as dyspnea, both because of the metabolic acidosis and the primary stimulation of the respiratory drive. And I won't go into how to take care of this person. Instead, I want to get to case 4, which was really fun from a couple of years ago when I was on wards at, actually, no, sorry, I was in the ICU at Montlake, actually. So here's case 4. You're on long call. Well, actually, we need to change the times, but that's what this was when we were doing 24-hour call. You get paged to the emergency room to admit Christy Leeds, a 37-year-old woman with a history of lupus and Evans syndrome. Evans syndrome is autoimmune hemolytic anemia and autoimmune thrombocytopenia, first described by Bud Evans, who is the chief of medicine at the VA here in Seattle. Evans syndrome carries his name. And she has had recent flares of her hemolytic anemia requiring very aggressive immunosuppression with all sorts of immunosuppressives, MMF, Cytoxan, Rituxan, steroids. And her baseline hematocrit is 18 to 21%. But she came in with severe progressive shortness of breath with exertion associated with chest heaviness and lightheadedness. But in the emergency room, her crit was 19%. It was at her baseline, and you're called to admit her. Again, her medications, MMF and prednisone for her autoimmune disease, dapsone for PJP prophylaxis. She's on folate. She's awake and alert, slightly increased work or breathing. She's afebrile. She's tachycardic, normotensive, a little tachypnic. Her SAT is 89 to 91% on variably 2 to 5 liters per minute nasal cannula. It's been fluctuating up and down, and the nurses and therapists are chasing it a little bit. No JVD. Her lungs are clear. She has a systolic ejection murmur, but no gallop, no cyanosis or edema. Her chest x-ray is clear, completely clear. Her ECG, no acute changes. Her hematocrit, I told you, is at baseline 19%. And her arterial blood gas, 737, 31, 92. So she's oxygenating well. At this point, it was 2 liters nasal cannula. And you can see that she likely has a little bit of a metabolic acidosis just from this blood gas. It looks like she's compensating for a metabolic acidosis. And in fact, the metabolic panel shows that she had a gap of 18. 20, an anion gap of 18. So what next? And here's our last poll. What would you do next? Would you order a CT pulmonary angiogram for her, transfer 2 units of Paxils, intubate for impending hypoxemic respiratory failure, order a replete blood gas with a co-oximetry panel, or order blood cultures and broad spectrum antibiotics?
I think this one's proving to be a little tricky for folks, so I'll give them a little bit more time.
Okay. The VA group looks like they were all conferring. And this is my last case, so we're doing well on time here. Oh, Brooke asks if I can go back a slide. I think I can. Oh, there. That one, Brooke?
Yep, thank you.
How we doing, Emily?
I might close this out. Okay.
Nice. Fantastic. A couple people are wondering if she has a PE, and boy, there are some things there that could make you worry about a PE. A quarter of you want co-oximetry, and then 2/3 of you want blood cultures and broad spectrum antibiotics. And that's not wrong. In fact, that was part of the care that she got that night. But the clue here is that her PO2 and her SAT are very different, and that she has an anion gap metabolic acidosis. And in fact, a co-oximetry panel was ordered, and she had a met hemoglobin level of 19.6. Everyone, oh my gosh, she had met hemoglobinemia. Anybody know why she has met hemoglobinemia? Yes, from the dapsone that she was on for her PJP prophylaxis. With a methemoglobin level of 19.6%, that's a very severe relative anemia, because the maximum her true SaO2 would be 80%. And that's why she was dyspneic, and that's why she had a metabolic acidosis. She was treated with methylene blue that night. The dapsone was discontinued, and she actually required a second round of treatment with methylene blue, but over the next few days, she got progressively better. So in wrapping up, please don't forget the non-cardiopulmonary causes of dyspnea: metabolic acidosis, sepsis, both relative and absolute anemia. And in this case, she had methemoglobinemia, ascites, which can restrict the lungs, neuromuscular disease, and anxiety. So these are always important to remember. And so in just wrapping up, we covered the mechanisms of dyspnea, some initial bedside evaluation, and some emergency care for some types of dyspnea. And we talked about the 3 pillars of care. When you're called to see someone with shortness of breath, think first about the safety net, get the patient safe, assess their vital signs, and then do your dyspnea survey, which includes all of these different clinical scenarios that involve the airway, breathing, circulation, neuromuscular deficits, and electrolytes. So thank you so much for your attention today. This was a few years old, but it's a bunch of interns at altitude, so probably short of breath, down by Mount Rainier. And before you go, I'm happy to answer any questions, but before you go, please use the QR code to evaluate the session. Thank you, everybody. Thanks, Kimia. Thanks, Brooke.
All right. Thank you so much. That was awesome. We'll hang tight for a minute. Thanks for doing the evaluation as well.
Cool. Thanks, VA. I think on Monday, I see everyone who's on immersion block too. I do my COPD talk on Monday.
Oh, awesome.
Yeah.